We have a patient. She is a 73-year-old female who was referred to the Barnes Jewish Hospital for the placement of an IVC filter. She was diagnosed with having DVT and was unable to tolerate anticoagulation due to multiple episodes of hematuria and gastrointestinal bleeding. So we did a cavagram. This was a cavagram still that is shown. So we measured her diameters. So you can appreciate the renal vein. You can appreciate the suprarenal IVC as being measured at 35 millimeters. The infrarenal IVC diameter was measured at 44 millimeters. So she was straight away diagnosed with having a megacava. Megacava is an indication, is a situation in which the IVC diameter is more than 28 millimeters. So her common iliac vein was then measured. The left one was measured at 16 millimeters and the right was measured at 11 millimeters. So these are her dimensions. So this is a CT scan showing her dilated IVC. You can appreciate the dilation. So in such cases, we have two options for IVC filter placement. One is a permanent filter, another is a retrievable double filters. The permanent filters which are used are bird's nest filter and an LGM filter. The LGM filter has been discontinued. This is a bird's nest filter. You can appreciate the strings of the filter. So this is a BNF that is deployed, but the problem with the BNF is that it requires a working vena cava diameter of up to 40 millimeters. So this was not an option in our case. It also requires a landing zone of 7 centimeters, which is the infrarenal length of IVC. So these are the risks which are associated with any filter placement, and which more commonly with a permanent filter. We have a venous axis that is seen in almost all cases. There might be a tilting of filter that is seen in 4.712% of the cases. There might be filter migration. In delayed complication, we still have thrombosis, filter fracture, and IVC perforation and infection. So in our institute, we use the Denali filter. This is the Denali filter that is seen. We can appreciate the apex, which has the hook, and these are the struts. So this is what a deployed Denali filter looks like. So these are the contents of the Denali filter. We can appreciate the dilator, the introducer sheath, and then we can appreciate the radio opaque markers that is seen. So these are 28 millimeters in diameter. So if we have to measure the cable diameters intraoperatively, we can use the dilator to measure the diameters. So in the procedure, so under sterile conditions, her right internal jugular vein was accessed with the help of an ultrasound. A guide wire was placed under fluoroscopic visualization. Her left common iliac vein was cannulated and the filter was placed. So this is a picture that shows both the filters that are in proper placement. The patient was then discharged to home care, and the plan was to follow up the patient for 1 to 2 months for filter retrieval. So this is a chart that shows the incidence of cable anomalies. The most common renal cable anomaly that we see is duplication, that is seen in 1% of the population. Then we have hypoplasia. Left-sided IVC in 0.4% of the population, hypoplasia in 0.3% of the population, and megacava in 0.1% of the population. So these are a couple of interesting cases. So the first, there is a CT still. You can appreciate the left-sided IVC in this case. So the filter placement in left-sided IVC. You can appreciate the filter. You can appreciate the angulation of the IVC. So this is a duplicate IVC system. So in such cases, so there is also two approaches we can have. We can either have a single suprarenal filter, or we can have two bilateral infrarenal IVC filters. So there's also a third option that the suprarenal IVC filter is associated with some higher incidence of renal failure, so it's not commonly used. So there's a third option in which if one of the IVCs is smaller and there's one dominant IVC, so we embolize the non-dominant IVC and we plan for a filter in the remaining patent IVC. So these are the two approaches. So on the left side we have two infrarenal IVC filters. On the right side we have one suprarenal IVC filter. So this was also an interesting case. So on the first image, you can see the right common iliac vein has been cannulated and DSA is performed. There was not any variant anatomy that was appreciated, and a single IVC filter was placed. So this was picked up by one of the radiologists. He noticed one a left-sided duplicate IVC system that might have been missed. So then then the left common iliac system was cannulated, and sure enough, there was a duplicate IVC system. So another filter was placed. So this is the last case. This is DSS still. This is a CT scan showing the cortical phase renal system. So yeah, you can appreciate in this system the two circumaortic renal veins. So this is the renal veins that have been cannulated. So the optimum filter location in such a case is to place the filter in the inferior to the most caudal IVC, the most caudal renal vein. So this is a picture that's depicting a wrong filter placement, improper filter placement. So you can appreciate the right-sided IVC and the two right-sided renal vein and the two left renal veins. So in such case, if the filter placed above the circumaortic renal veins, there is increased risk of renal vein thrombosis. There is also a risk of thrombus bypassing the renal vein system, bypassing the filter system that is shown by the arrows. So what are the important considerations? So the safety profile of the bilateral iliac filter placement is lacking, with the largest study till date only having a cohort of 10 patients. With the iliac filter placement is still an off-label indication for IVC filters, and retrieval of filters is routine except for the angulation of the left iliac vein. So this is a possible approach for the retrieval of the left common iliac system. So the right one was pretty straightforward, but for the left one, they used a 90-degree 7 French pigtail catheter, which was trimmed, and the trilobed snare was passed through it. So this was interesting to use improvised device for the angulated approach. So in conclusion, there's an importance of cavography, along with analysis of cross-sectional imaging, is essential for us to establish any anatomy and to look for caval thrombosis. Cavography should be done by cannulating the left common iliac system to look for any variant anatomy. Caval diameters should and be done before and are required to be done before proper filter deployment and to prevent filter migration. These are my references. Thank you.